And may I introduce the next speaker, who is Cicero Urban, very well known by all the participants, Brazilian surgeon, wonderful Brazilian surgeon, who will talk about the complications with implants on what he does in those cases. Thank you, Cicero. Muito obrigado.
Thank you for this invitation, yes, Sam, and all the organizer. It is a pleasure to be with you. Although I will talk about an unpleasant topic, but it is a topic that we have in our, something that it's unpleasant, but we have in our lives as surgeons. So my topic is complications with implants, what I do with this. I don't have no conflicts of interest. Some of these complications are not mine, but could be mine, of course. And some of these cases could have more than one alternative to solve them. And I will try to do a presentation which will be more conceptual and practical one. So it is how I do it in my practice. The aim of this presentation is to show a logical way to organize our decision-making process in case of implant complications and try to avoid them whenever it's possible in our practice. And I will show you 4 practical golden secrets. Well, what I not be able to show in this presentation, I'll not be able to show how to solve all or prevent all complications with breast implants, but we will discuss the most frequent ones in our practice. Every one of us has some regrets about some operated case that complicated. So it is part of our lives as surgeons. And the first secret here, I think that Regis already talked about it, and Benigno also. Breast implants, complications, I mean, and breast implants, of course, have complications, and complications in oncoplastic and reconstructive surgery in general is not uncommon, unfortunately. Well, and it is part of our lives, but there is an impact of complications on patient satisfaction. This is a negative line here. We have a negative line when we have a complication in terms of satisfaction from our patients. And we have, in general, 3 types of complications related to breast implants, conceptually speaking. First of them, we have specific complications of breast implants. We have complications with implants. I mean, complications that belongs to the mastectomy flaps, but we have an implant inside. And we have the third one, which is the most complicated of them and maybe the most complex to solve, which are the emotional problems related to breast reconstruction. The second secret here, most relevant failures in our practice are not the technical ones. They come from misjudgment. So the most significant question here is not what is the best conduct, but how to decide, considering values involving an evidence-based medicine. Complications which are off breast implants, BLCL, AZ syndrome, late seromas, capsular contracture, extrusions, animated breast, rippling, and rupture. These are complications which are related, but they are all off breast implants, not from mastectomy, but these are from implants. And we have mastectomy complications with breast implant inside, flat necrosis, infections, wound dehiscence. So they can be worse when we have mastectomy, for example, with immediate breast reconstruction. Late seromas, as in this case, we can have late seromas from infection, we can have late seromas from BLCL, we can have late seromas from trauma. Most frequent of them are from trauma. Trauma, microtraumas or macrotraumas. But seroma is a sign, it's not a disease to be treated. Most of times they end alone without any intervention. And seroma treatment, no. Seroma is not for treatment of the cause of the seroma. That's the, And we have three different situations. For example, BLCL, positive culture, or negative culture. Three different scenarios, we must have different treatments. So for the BLCL, the protocol for BLCL, I will not discuss here, but positive culture, for example, it's most of the time is necessary to remove the implant. Negative culture, if you have a seroma recurrence, most of times it's necessary to remove the prosthesis and maybe remove the capsula and then replace in 3 months after with a new implant if it is necessary. Well, second big complication, capsular contracture. It's necessary after reconstruction to think about it is with or without radiotherapy because it's different. We have three classes of correction here, possible or impossible. Sometimes it's impossible to do a correction. Simple or complex. It's necessary to be more simple first and then go to complex step by step. And evidence-based or not evidence-based. Most of our corrections are possible, complex, and unfortunately, experience-based, not evidence-based medicine in terms of level 1 or level 2. So capsular contracture without radiotherapy, for example, this case, bilateral mastectomy, immediate reconstructive definitive implants, this asymmetry we can do just a capsulotomy and change of the implants, and we have a nice result. With radiotherapy is more complex. I did a tram flap in here and necrosis. How can I solve this problem? With another flap, early flap, to save the trans disaster. Capsular contracture with radiotherapy, this case bilateral radiotherapy, bilateral cancer. So just a simple correction with lipofilling. Let's go to another big problem, extrusion. Again, with or without radiotherapy. Without radiotherapy is easier. I can solve this just putting a temporary expander, for example, or maybe rotation of a flap like this case, and we have a good result. It's not so difficult to do. But when we have, for example, a case like this one, mastectomy with radiotherapy, reconstruction of a temporary expander, change of the expander for an implant, radiotherapy and bubble sign and extrusion, a disaster, a disaster. Then I rotate, I did an LD flap, and again, with the LD flap, again on extrusion. So how to solve this problem? Well, a tram flap. So 2 flaps to solve the same problem. 2 flaps in the same patient. And again, now we have like the feeling to solve this kind of problem. For example, 67 years old, T2 and 2 radiotherapy in the mastectomy flap. She lose the implant, and we did lipofilling in 2 sessions and plus an expander. It is possible to expand a skin even with radiotherapy when you do lipofilling together, and then this is the result at 4 years after. So we can do maybe a simple technique to solve a big problem, a complex case. Implant rupture, not so frequent, but part of our lives when we have more age. So more than 10 years after reconstructions, for example, 82 years old, mastectomy, immediate post-reconstruction of the implant. Now capsular contracture and implant rupture. What did you do in this case? Patient didn't want to new breast prosthesis, only removing the prosthesis, improve the symmetry in a fast and low morbidity surgery. So it is better without implants than with implant. Third secret, KISS, not kiss me. Keep it simple, stupid. Lower surgeon's expectations. Sometimes we want something perfect in terms of symmetry, in terms of aesthetics, but could be not the best for the patient. Other complications, flat necrosis. This is not from implant, but it is with implant. So these are patients that have high risk for these kind of complications: smokers, obese patients, radiotherapy flaps, quality of the flap, so the quality of the mastectomy, and neoadjuvant chemotherapy is something that can add in terms of complications. Again, with or without radiotherapy. Radiotherapy, no radiotherapy, just to put some stitches here, we have 50 to 60% of chance to solve this problem. But without radiotherapy, with radiotherapy, this is a big disaster. This is an ADM inside, irradiated flap, and it is unfortunately, she is a physician. So small and big disasters. This is a big disaster. This is a small disaster, but we can solve with a simple technique. Here, more complex. Infection. Infection, most of times, if you have this kind of purulent inside of this, it's not possible to solve this. So just remove this implant, wait 3 months, and then put in the temporary expander, expand again the skin, and then it's possible to save this situation, but removing the implant. Rippling. Rippling is something that belongs to implant and to the flap of mastectomy or to the characters of the patient. For rippling, most of times we can solve with lipofilling. Emotional problems, which is the most difficult of them in the final part of my presentation. This is the possible outcome, and sometimes it is the patient's expectations, which is much more difficult to deal with than technical ones. We have 3 classes of patients: those with good results and those with better results, those satisfied and those unsatisfied, those with good relationship and those with better relationship with the surgeons. This is the trial for medical claim. Bad result, unsatisfied patient, and bad relationship. So be aware of them. This Regis told about this editorial. I think that's important to you to read it, because under promise and over deliver is the secret of good conditions for breast reconstruction. Poor cosmetic outcome litigation was very rare in the past, but it is becoming more frequent nowadays with oncoplastics and reconstruction surgery. The secret, maybe the most important, the 4th one: lower patient expectations in breast reconstruction surgery. This is not aesthetic surgery. This is not aesthetic surgery. And of course, these are some impossible corrections. It's not possible to solve some of these situations, and don't promise to your patients. In conclusion, complications, unfortunately, are part and most unpleasant part of our job, but how to solve them and how to prevent should be included in the skills pocket. Time and experience reduce our risks and better our competence to prevent and solve them. Oncoplastic and reconstructive surgery is not aesthetic surgery, and this should be clear to our patient in pre-op period. And for our reflection, I like this. For each complex problem, there is a clear, simple, and wrong answer. Think about it. Thank you.